What we're going to do now is actually have a few other people come up to join us and have continue this discussion, because obviously there was some serious discussion, serious data discussed there, but also Julie wasn't quite as serious as Curtis, so we have to we do actually want to discuss some of the finer points of this and actually talk about making this a reality. So if I could ask Shannon Taylor, who's a hepatitis C treatment nurse, and Gary Hales, who is a community representative and a hepatitis C patient who has volunteered to join us on the panel today, as well as Dr. Heim, who's going to come up and give us a European perspective, and Dr. Aurora unfortunately had to catch a flight to India, so he's going to give his regrets. But maybe would Dr. Terrell, would you mind joining us up here as well?
That's good.
And so what we're going to do is continue the discussion about treating hepatitis C in primary care versus specialists. And I guess I'm going to start with a question for Julie. And my question is, you made the case that we could have primary care physicians treat some of the easier to treat and less complicated patients. But I guess one of the issues is still going to be around assessing the severity of liver disease, because I think, as Dr. Terrell made the point very clearly this morning, that although elimination in Canada might be a goal, at least in the financial scenario we are right now, elimination is going to be a major challenge. So if we can't treat everybody, are primary care docs able and willing to figure out who we should treat?
Well, actually, I don't think it's that complicated, because assessing the liver condition, most of the cases is either it's sick and you have signs of cirrhosis, or you have a patient that is in relatively good condition and you have all these, the fibroscan and the indicators, the markers of fibrosis that you can calculate, that gives you a good idea. Then you collaborate with your colleagues, specialists. 5 years ago, most people were doing biopsies or 10 years ago, they were doing biopsies before treating. This is not the case. The other thing is, you can decide that in your society you treat everybody, and we need a strategy for that. But certainly, what I mean is, in this curve, there are cases that are in the gray zone. There are many cases that are in either. And I think we could do the parallel with diabetes. And diabetes is a specialty of primary care. You cannot treat all the diabetic patients in specialized care. So if you give the mandate to the primary care physician, which was my proposal, saying, they don't take it because everybody says you're not as good to take it. So if you take it, then you give them the means to do it, and that's it. It's not that complicated.
Good. Anyone who wants to join in, just grab the mic.
Yeah.
So, I mean, I've always thought that this keeping ourselves in our own silos, in our own professions, is very destructive, and it certainly doesn't help patients. So, I mean, the physicians cluster together as a group in the hospitals, and then the GPs cluster together, and the nurses cluster together, and the social workers, and different patient groups. That just doesn't help anybody. And you can feel that creeping into the way we behave on a daily basis, and you've got to just say, stop, this is not the way that we move forward in helping patients, which at the end of the day is what we're all trying to do. I have very little tolerance for this. Oh, I'm a big shot at a hospital, and that GP is they're dumb. That's why they're a GP. It's I hope that most of us realize that's just simply not the case. I think as far as
is this an apology? I'm just kidding.
I was given a task to do. Okay, I sat through 8 hours of everything, of information that went against my statement. So I don't accept that, it was, you were at a disadvantage. I was at a disadvantage. But you need, I think there's 3 key aspects that need to go into being a good hepatitis C treater. You need to be committed. You can't just dabble in this. Okay, you need to be in a whole hog. You need to know your stuff. Okay, and that again is taking, making a commitment to knowing the information. Whether you're a doc or a nurse or a social worker or a peer supporter, you need to know what you're talking about so that you don't contribute to this morass of misinformation that's out there about hepatitis C. And you need to care. Okay, and as was said earlier on today, if you care, that really kind of melts away a lot of the barriers. Patients sense that. So my point about patients not, they'll be willing to go to more difficult places like the hospital or the clinic on the other side of town if when they get there, they're respected and they see that there are competent people that actually care about them. Okay? So, I mean, I realize I'm preaching to the choir here, but that's what you need.
Maybe Shannon, I'll ask you if you can just give us a comment from a nursing perspective, where hepatitis C nursing is going, and whether, I mean, we've talked a lot about primary care physicians, but what about other types of healthcare providers, particularly nurses providing hep C care?
Sure. So I used to call myself a hep C treatment nurse. Now I call myself a hep C resource nurse, because treatment is not just the medications. And so receiving a prescription from either a big-time specialist, a super specialist.
That's me.
I love the super specialist this morning. Or a general practitioner in the community, their treatment is a whole lot of other aspects of this as well. So now I'd like to see hep C, and I've been a nurse for 17 years, so not as long as you, but I've been in primary care in 4 different provinces. I have been treating hepatitis C since I started treating it in 2005 in a low-threshold methadone clinic in Halifax, based on the Pender model. So, and that was with a GP who had done a fellowship in hepatology. I've worked in an outpatient hospital-based liver clinic with an internist and a gastroenterologist. Now I work in 2 different CHCs here in Toronto with GPs, nurse practitioners, outreach workers, community support workers, and people with lived experience. So I kind of have been doing hep C treatment and the big, broad version of hep C treatment for a long time, and lots of different models. It doesn't actually matter which model, I think we all know that, but I just really wanted to open it up a little bit more. You need nurses, so let's never excuse the nurses from the conversations. You need all of the other elements as well, of course, too, in order to get people engaged in care and use hepatitis C as your conversation starter around healthcare. You have to have some outreach that is hitting the sidewalks. Jordan, you asked a question this morning about how can we educate ourselves, we who come from within the academic or the hospital world, how can we educate ourselves about the social determinants of health? Your outreach workers and the peer components of your program are going to help educate you. Take a walk in the community and use some of the tools of engagement, like maybe water for a crystal meth user. Whatever it takes, a pair of mittens. To start a convert foot care is a good one. Doesn't have to be about hep C, because that conversation will come out. They're going to feel that you care. And really, hep C it's what brought us all here today, but it may not be we talk about competing priorities, but I tell a lot of my clients that they'll probably die with hepatitis C, not of hepatitis C. So the other determinants of health that are going to impact them are where we can make a difference outside And so I think that's where I'll stop.
Thanks. Jason, comment?
All right, so there's been a lot of discussion today around sort of the cost of medications and how we're going to have to somehow triage patients with advanced disease. So I guess I'm sort of curious to the panel. My personal opinion is I think that some of the sort of non-invasive measures of measuring liver fibrosis, such as FibroScan, might be one potential tool that we can sort of use to increase HCV assessment in the community, or at least liver disease. So I guess I'm just curious in terms of, from the panel's perspective, from all disciplines, how might we be able to achieve that in the primary care setting in terms of enhancing assessment with non-invasive mechanisms? And, you know, to have them, to refer them to a specialist to go get a FibroScan is not going to really, you know, take out the bottleneck that's occurring. So I'd be interested to sort of hear your thoughts about that.
Well, anyway, Marcus, do you want to make a comment?
You know, I think the costs are really the crucial point here, and there is a lot of wishful thinking here, but the reality will be, I think, quite different. Maybe in the future, in 10 years and 15 years, there will be cheap and effective drugs, treatments for hepatitis C, and I think in that setting, treatment of hepatitis C will go completely away from hepatologists and infectious disease specialists and will be done by general practitioners. This will be a time when Hep C testing has become part of a routine checkup, and if it's positive, you make a HCV RNA test. If it's positive, you prescribe a pill for 8 weeks, and maybe you do a retest, maybe even not, to see if it has worked or not. It's going to be a very easy treatment, and it's going to be standard of care for a GP. For the time being, I mean, I've shown you the costs that this will put on the healthcare systems. I can tell you, certainly in Switzerland, access to these treatments will be restricted, will have to be prioritized. And who is going to do the prioritization? It's going to be in the centers. It's going to be in the centers with experience, and not because the GPs are not as good. Maybe they are not. That's debatable. But because the insurance companies and the payers will have to want control over who is prescribing this. And just a last sentence. In Switzerland, in general, drugs can be prescribed by every physician that has a license, a state license. And there are some exceptions. Expensive drugs for cancer treatments is one. And there is now one exception, another one, and this is telaprevir and boceprevir. Those were the first drugs now that also have been restricted to be prescribed by hepatologists, infectious disease people. And I'm very sure that the next generation of HCV drugs will be restricted again to the same profession. Not because the others cannot do the job, but just because the payers want to control who is prescribing.
Look, I think it's going to vary by country, but I think I just want to make 2 points. I think the first point is that, you know, the specialist-based clinics, they already have long wait lists. So even though we're going to have these brand new regimens, I agree, it's not going to be this massive expansion. And I think the second issue is
that's what they want. They want wait lists. You cannot. But you know, if you want to treat now all that are positive in the next year, I mean, who is going to pay that? Nobody can afford it.
But that's why it's important to triage patients, and we'll need to do that within the community, I think. Anyways, Julie?
Yeah, I'm just jumping. We had a similar conversation a few weeks ago with a researcher in global health. And what is very interesting here, if we had tomorrow a cure for cancer, a cure, okay? 3 months treatment, cure for cancer, we wouldn't have this conversation here around the cost of that medication, because everybody knows about all this impact of treating chronic disease. recently in Quebec, we had a medication that was cut from the list from no reason, that is for alcoholics. Methadone, buprenorphine, very complicated to have license to prescribe, etc. So we're maybe hitting here some kind of discrimination against our idea of how we look at this treatment, and maybe because it's vulnerable population. And I think we have to set, when we're talking cost, I agree with you, but it doesn't make any sense if we have a very good treatment, and we've seen a lot of things today, 10,000 a year for an HIV patient for the life versus 80,000, let's say 70,000. So I think we have to think it through as far as access and how we see this population and how we deploy these things. As far as who decide who are the good patient and the bad patient, I'm not that sure it has to be a specialist versus someone who is specialized in addiction, for instance. So
I guess the one difference that I think is important to remember is that not everybody with Hep C infection dies of Hep C, and I think that does distinguish it from HIV and cancer. And so you have to start thinking about it both on a per patient level and then a public health epidemiology level. And there are different reasons to treat people, but but the cost, and other issues. But
prevention of cancer. Then
I'm not disputing that, but
just go to prostate cancer. I guarantee.
Right.
Woo.
Yeah.
Hello. Every guy doesn't die in 20 years.
True. I want to ask Gary. I do want to ask Gary, if we could ask at your perspective on this debate, and if you have been through treatment before, and the idea of these newer therapies, whether you would be more or less comfortable with in a primary care facility or with a specialist, just to try to, and obviously this is your opinion, it's just speaking for yourself, but just to give us some sense of that.
I'm just glad you didn't ask me about prostate cancer. I've been treated twice, both times at a downtown hospital, and I would certainly look at using a smaller place, a clinic, as opposed to continuing at the large hospital.
Any reason for that?
Well, the hospitals are wonderful places. They're just not particularly good for patients.
Kurt, has Julie brainwashed him before?
I am wounded.
I would say the difference in the price of parking might be one of the factors. Can I just say that I really do think we have to think carefully about this as if we're treating for prevention. And all of these high-risk people that spread the disease, we have to treat everybody who's positive, not trying to striate the disease as being cirrhosis or F3, F4 before we treat them. In the large population that is not spreading the disease, absolutely, you got to do a striation of who you're going to treat in that group, because there are a number of them, unlike hepatitis B, where you can get hepatocellular carcinoma in patients that do not have cirrhosis. In this disease, most of them have advanced diseases before they get the complications. And so it'll be important, because many of the people who have hepatitis C in that big population probably will never die from hepatitis C. And there is importance in doing an evaluation and striating and thinking, who should we be treating in that group compared to the group that are the high spreaders. And that, because I still think you need to think about treatment as a prevention, as we've seen in HIV, how this can help, and we need to have that type of thought here as well.
Yeah, let's go to the mic.
Yeah, sure. I'd like to back up what this gentleman said about being really comfortable with the idea of being treated not by a hospital, or not in a hospital, by a family practitioner would be fine with me. And But I also wanted to back up what this gentleman said about pre-assessment of patients. I have gone to treatment twice as well, and I'm pretty much asymptomatic. And just before I went to the second treatment, I was given a fibroscan, and cirrhosis, I believe, is from 17 to 75 kPa on the fibroscan scale, and my score was 49.6, and so that's pretty advanced cirrhosis, and I didn't realize it. And 13 months following my treatment, I was down to 18 kPa. So I think that it was really valuable that I was given that pre-assessment. And it's like you were saying, that patients who don't have as much symptoms, could probably be treated by a family practitioner. But just make sure that all, that the proper assessment is done in advance.
Oh, it's a very helpful point to make the point that even people with cirrhosis may be perfectly asymptomatic and may have even normal blood tests, so it's not always so easy to pick them up.
Yeah, thank you.
Sure.
So, the way we've structured our clinic is we work with all of our community partners. We have a community liaison that links with the downtown shelters and the downtown clinics. We have a telemedicine program and a rural nurse that travels from community to community. And we use all our staff and all these technologies to try and figure out what the patient wants. Now, there are some patients, they want every single visit done at the hospital. There are some patients that never end up coming to the hospital. We work with their primary caregivers and their nurse practitioners and their social workers, and we try to package a care for that specific person based on what they need. And we've found that it works. So, I absolutely, some hospitals aren't a great place. They can be if you make it that way. But yeah, I get it. People don't like hanging out there. I've been a patient. I don't like hanging out there either. But it's, you need to figure out what the patient wants and try to do that.
Mel?
So, there's clearly going to be a cost issue, and there's probably not a capacity issue if you deliver it differently and the drugs are there. But what we heard today was that in our current process, there's no systematic triage of people for care, both from the vulnerable populations nor for the baby boomers, and that a substantial proportion of people are not diagnosed. So unless you actually take the effort to assess who is infected that we don't know about, we haven't designed the system to respond to those needs. And in so doing, from a public health perspective, maintaining the current structure doesn't serve optimum care in any way, neither for the people who are vulnerable and still getting infected, who need a whole bunch of other things to support their health inequities, nor for the baby boomers who aren't being triaged because they don't even know they're infected. The second thing is we worry about costs. But if you look at the costs we spend in our correctional systems, and you look at the costs that we spend for our policing, the costs are being spent basically like spinning down the toilet. And it's really about, could we marshal the support in our country to recognize that you do have a curable illness, there is a population that could be supported much more effectively, and in order to do that, we do need that federal strategy.
Do you want to make a comment?
I would like to go back to what Lauren said, and I think this is really a very good point. And there is the population that spreads the disease, and I think the infection should be treated. And in my view, the best setting for these patients, for the large majority of these patients, is in addiction medicine centers, be it in a practice, in a community, or be it at a hospital, they are not very often and not very successfully treated by gastroenterologists, hepatologists, by GPs. They are really, I think the best care for them is taken by addiction medicine specialist centers. And they should be given the resources to use these new drugs, because we cannot treat these patients with interferon-based treatments. And then the other large population, which is not spreading the disease, I think there we have to prioritize who needs the treatment most, and that, I think, is our job. And it's not the job of the GPs, I'm sorry to say that. I think there it is really a matter of experience. The more experience you have, the faster you can do good priority decisions. That's.
Can I just add a little?
Yeah, you know,
The super specialist.
I would be more than happy to send my patient to a lot of GPs that I know with hepatitis C. So I don't think we need to be specialty snobs. If you have the commitment to know about hepatitis C, I think any family physician or nurse practitioner can manage it just as well as I can.
Yeah, I just want to warn about treatment for prevention for drug users, because I'm an addiction specialist. So it's and when we're talking in addiction places, it works well when you have in Switzerland, because most of them are on methadone or maybe on methadone, which is quite different in Canada with cocaine. So and most of the cocaine users want to have a Hep C treatment in general go well and stop drug during the treatment, in my experience, but they have enough of their 12-step 4 program that they've done already, so they don't want to be treated in a pure addiction ward. So we have to be very careful about this. The other small point I want to make is, be very careful as well, because if you say only the ones that are very destructive and share needles and will be treated with the nice medication, so everybody will go back to their syringes to get treated. I'm a bit characterized.
Sure.
So part of the argument about the cost is limiting the viral spread, because it's been said a couple of times, this is the cohort that's going to be, active users are going to be spreading the virus. Not necessarily. So education about harm reduction is a big piece. And so talking with your client who is RNA positive about how not to harm others with their blood is a really good way to start that conversation. And that's why we need the other piece of the strategy, which is not just a needle exchange, but a comprehensive laundry list of all the harm reduction supplies, so that people can, I think it's quite insulting actually to assume that someone's just willy-nilly going to spray their virus all over their community, and somebody said yesterday, you don't mess up your own bed. So we don't want to hurt each other. And if I have a virus, I would rather know that I have it and I can protect my peers around me. So give me the chance to learn that and give me the tools to do that properly. And then I may never need these medications, but I certainly won't, I'll be responsible for my own virus. So.
Maxime?
Thank you. For the sake of stimulating the debate, I would like to present a couple of evolving pieces of evidence. One is that the new knowledge about treatment is evolving at a pace that has not existed before. The information is being generated at a scale that has not existed before, and which represent a challenge for both specialists and primary care physicians in terms of to keep up with the up-to-date standards of treatment. Well, maybe not even standards. Standards is something that has been established as a standard, but with the best practices that are evolving fast. the issue of human mistake becomes really critical, and it's equally affects specialists and primary care physicians. So then the debate is really maybe, in my view, between whether HCV is being treated by the right people or whether it's being treated by people who are not qualified, without the real attribution to specialists or primary care physicians. And in light of this, I was just wondering, what do you think about the evolving new technologies, technologies that help us to manage information flows, to prevent physicians from overprescription or prescribing doses that are potentially may cause adverse reactions, or do you think this will have a profound effect of how effective treatment is rolled out with the cascade of care?
I mean, if I might add, I think it's a good point you make, that it really doesn't matter whether someone's a specialist. I mean, they actually showed data at the ASLD this year that showed with telaprevir and boceprevir that up to a half of patients didn't have HCV RNA testing done at the right time to make decisions about shortening therapy or stopping therapy. So this, and this was almost exclusively prescribed by specialists, but these people may not be specialists enough. And I guess the only thing I would say is that the field is changing rapidly enough and treatment is getting simpler enough that I think there will be a period of transition where there's a lot of confusion about what's the right regimen, which patient should be treated with what, and what do you do with treatment failures. But I do imagine that Marcus's vision is probably correct, that we will get to a period where we will have forgiving therapies that even when they don't work, there's something else that you can use, and almost everybody will be able to be treated with a very simple regimen. But I do think we haven't been good enough about adopting sort of, I guess what I would call treatment support technology to help make those decisions. So for example, I think with telaprevir and boceprevir, it would have been really helpful to have had more things like, similar to my fairly rudimentary Excel spreadsheet that some of you used to help go through treatment, which I used, but it wasn't very good. And I think I think you're right that suggestion to adopt those things would be helpful. We will keep moving to Frank.
The debate is really quite amusing, interesting. But the reality is that the person who has HCV is initially diagnosed by the family doctor in almost all cases. I mean, it wouldn't be, why would that person be initially diagnosed with it by the specialist? I presume that the specialist comes second to that, unless there's some other kind of a crazy situation. In Toronto, that's fine. I mean, I'm a survivor of hepatitis C. So I go to my family doctor. My family doctor says, you got some liver problems, I'm not sure what they are, repeats the blood tests, and says, I've heard of a doctor down at the Toronto Western who is a student of Sherlock, right?
Sherlock.
Yeah,
Yep, you're right.
Of Sherlock, right? And so then I become a patient of Jenny. If I'm living in Moose Factory, and the same thing happens, then that doctor perhaps knows of someone to send me to, but I'm 500 miles away. What I want to know is, does that doctor have enough information about who to ask to treat me? I think that's really the issue. For a lot of Canadians, it's kind of what we heard this morning with respect to New Mexico.
No, it's too difficult for patients and for primary care givers to find the people in the know, and so we on a provincial level in each of our provinces, we need to develop these types of systems. I know there's some Ministry of Health people in the audience who are probably working on that right now.
And one of the reasons is because primary care physicians don't see that in their plate as something they have to do.
know, yeah.
And I think it has to come from the College of Family Physicians. I've been struggling with this with addiction for many, many years. And it's the same type of thing where if you have a patient with those chronic care managed illnesses like diabetes, hypertension, then they know how to do it and they know how to develop it and to evaluate this. When it comes to those disease that belongs to the specialist, they don't feel that it's in their own park. So I think there is something to go with this.
But I think there's also an issue about just getting it out into the general knowledge among physicians, because when physicians went to medical school 20 years ago, Hep C wasn't curable and there weren't. So I think part of that is just actually getting it to permeate beyond people who are attending a meeting like this, which is, I think, a challenge. And maybe we'll have our two guest speakers finish off this discussion with some comments.
A quick cautionary tale about national strategies. Australia has just finished its third 4-year national strategy and we're drafting the 4th strategy. And it would be wonderful to think about what we could do with the reinvestment of money that's wasted on the incarceration of people who use or possess illicit drugs. And we could have specialty and primary healthcare clinics in every community across the country. Wouldn't that be wonderful? But in our 12 years of working with a national strategy, each evaluation of that has been that the criminalisation, the legal issues, the stigma and discrimination are ones which have achieved least progress in every single time period. So a cautionary strategy, if Canada does achieve a national strategy, that is an absolute focus of energy, because it's money wasted that could be used in such better purposes for care, treatment and prevention.
Amen. Thank you.
This was so entertaining. One of the interesting things that is that you keep talking about care and treatment, but I don't know how many times we've seen that continuum thing, and it really all starts with screening. And our philosophy is meeting the patient where they're at, and I think that you're all truly engaged at that level. We meet the patient where they're at so that we can give them. But the screening issues are really as important as the treatment issues, because we're now being asked to screen a population that, the baby boomer population, like it or not, still has a very low prevalence of infection compared to our high-risk population. We only have one antibody test that can't be confirmed with anything. The rates of false positives of that antibody test are going to be quite high. No one's talking about that. Confirmatory testing costs a lot. And so meeting, doing specialists, generalists, whoever it's at, but the starting at the beginning, I think also needs to be addressed, and educating people on how to do proper screening. People walk around, by the way, with acute infection with no antibodies for 2 months. They don't know they have virus because we're not screening for virus as a regular thing, because it costs a lot of money. And so when we talk about money, we have to start thinking about things beyond just treatment, but other things too. And I just want to hear from the panel about that.
Well, I'll just say that if we just published a paper on testing HCV negative active drug users, and it showed that by testing them regularly, their risk goes down. And we haven't seen that with HCV positive. So maybe the message that we're giving to HCV negative to protect themselves is much better than the message we give to the ones that we could think of the differential message. But what it also says is if primary care nurses, outreach worker, primary care physicians, and all the people that meet these individuals are able to test them before they get infected, then you may have something going on. And if they get infected, they're going to have a primary care person to go to and say, whoa, I got infected, I might be treated. So there is a kind of an argument to say we have to implicate primary care health worker now, that in 5 years from now, when all the treatments will be more affordable, more easy to administer, then they'll be ready to treat. The ones that are experienced enough, of course.
But I think the other thing that I would add, I mean, one of the things we discussed when we've talked about introducing baby boomer screening here is, first of all, whether there are other tests that could be used other than antibody as a screening test, and also whether you could have reflex testing for viremia in all positives. And the economics, I mean, to be honest, it's not in the CDC model for looking at the health economics of, so they don't talk about the test that you have to go back and see somebody to confirm that that's positive, that you then get a referral and all the additional costs that are involved in that. So I think it's absolutely a good point, and we need better point of care testing that's ideally not a test for antibody, but a test for viremia, which I don't think is impossible to keep it cost effective. Comment?
Just very small comment. Thank you very much for presentation. It was very interesting. But as a nurse and hearing everything you said, I think that there's a place for everyone in Hep C treatment, either the nurse, GPs, specialists, and it's a teamwork. And I really think that the first thing to look at is the patient. He must know he has an Hep C. So if there should be a screening test done, it must be done. Then we're going to see if the patient needs to be treated or not. But if he does not need to be treated, because maybe he will never have any problem with his Hep C, he will know about it, he will know what to do about it, so he won't infect anyone else, but he will have a good follow-up, and we'll see what time, if he needs a treatment or not. And the one who needs to be treated, then they will be, and then we will prevent bigger problem. So I think it's a teamwork, and that's, I think, the main thing to remind about that. Thank you very much.
Maybe Adil, if you want to just give us the last comment of the day, the last word.
Yeah, so I'm going to state the obvious, and sorry, Curtis, but I'm going to defer with you. In the light of what was debated, frankly, we don't have a choice but to have GPs involved, because otherwise the disease is not going to go away from Canada. You can look at whichever estimates you want. The current treatment rates cannot sort of match up with the number of patients you have identified year on year. And with the immigration increasing and we are not taking any measures to prevent the disease from spreading, those numbers will remain and the treatment numbers will remain. The second thing is there's actually a lot, everyone talked about the costs of the drugs that are in the system, but there are actually a lot of hidden costs when you bring a patient in from 100 miles away. Their cost, the unfortunate part is that the government is very siloed, and they say, well, this comes from my drug budget, and this comes from my hospital budget, and this comes from my X budget. So if you actually take those costs into account, it's actually much cheaper to have a hub and spoke model where with proper super expertise being translated to GPs, you can actually treat it.
You will be horrified to learn that I am in the midst of cloning myself. There will be an army of me to treat all people with hepatitis C.
In 20-something.
Wow, that's
unfortunately, the cost of that was $300 trillion.
Anyway, thanks, Jordan.
Only slightly cheaper than treating everyone with sofosbuvir, right? Okay, thanks. So thanks. So I'm going to now thank the panel and the attendees for your participation in that discussion. I think it was an interesting and although somewhat tongue-in-cheek debate. I think we did cover some important issues, and I thank you for that. And then I'm just going to quickly take my prerogative as having chaired this meeting this year to say some thank yous and to just highlight a few important points that we saw today. So first of all, I would really like to thank our speakers who have come, some of them have really come from across the world, and all of them have braved the cold and the snow. So kudos to you. I'll maybe just quickly, with a very, very punctuated point, highlight the points that they made. We started the day with really an excellent introduction from Dr. Terrell about giving us a vision of what the burden of this disease is and what Canada's response needs to be. And I think he's given us a challenge, which is not eradication, but elimination of this disease in Canada. And it's not something we're going to achieve tomorrow, but I think he's really put that as the thing that we should be aiming for in the longer term. Everyone was inspired by Sanjeev Arora's discussion about Project Echo, and I was glad that he came. I've heard him speak multiple times, and every time I hear him, I get excited about it, and I really think it's a project that is made for Canada. We are a geographically challenged country, and this project can overcome a lot of those challenges. And then we heard from Marina about how a really outstanding network across the country has really made some excellent progress in treating HIV Hep C co-infection, but she also highlighted a number of the challenges that still exist in there. Marcus and Nagla convinced us that the immune system is still important to hepatitis C, and I know as someone who shares Marcus' passion for interferon, it's a little bit bittersweet that we're getting rid of this drug, which is terrible for patients and providers, but I will say has taught us a huge amount about understanding the innate antiviral immune response, and I hope that we'll continue to learn more about it from people like Marcus and others, and Nagla showed us, and hopefully that her work on understanding acute clearance will help to lead Dr. Houghton and others in the pursuit of developing a vaccine, which is not a pipe dream. Kim Page is leading one of the first trials of a vaccine candidate, so it's not something we can't imagine. We then had two great discussions about the behavioral sciences from Carla all the way from Australia and from Louise closer to home, talking about some of the social issues and behavioral challenges of treating this disease, and remembering that we have to perhaps not talk about these people as patients but clients, something that's very hard for physicians to change their speech, but people in general, just hepatitis C infected people or people with hepatitis C infection, and try to remember that there's a lot of other issues that go into managing and treating this disease, and it's not just a virus. And then I think I was really happy that we got participation this year from the Public Health Agency of Canada, and I really thank both of our speakers from PHAC for joining us today. Maxime, I think it was really helpful to see the data that the agency is putting together to try to show us what is the burden and what is the number, who are the number of people infected in the country. Those numbers are critical because without those numbers, it's impossible for us to even speculate on what are the costs and the future burdens to the healthcare system. And perhaps we gave our agency friends a bit of a tough time, but I think Mark's point about the fact that maybe sometimes the priorities haven't been dead on and we have to start thinking about developing a national strategy is something that certainly I'm supportive of, and I think there is support for that among other members here, and we can hopefully move forward to that. And then we finished off the day with some discussion about the epidemiology. Kim Page, always entertaining, and in addition, very insightful, so thank you for your comments, and then I think that led really well into a discussion that we really haven't involved. We talk a lot about what primary care providers might need, but it was really helpful to have Kathy come down from Sioux Lookout to give us really a real world vision of what are some of the challenges of delivering care in some of the isolated communities, in particularly the First Nations population. But so thank you for coming and sharing your experiences and some of those challenges. And then I don't think I need to say anything about our debaters. They did a great job, took off the gloves, and really ended the day with, I think there's general consensus in this audience that this is clearly something that needs to be done as a team approach, but I think that they did highlight some of the challenges on both sides that family care, family physicians will have in terms of managing the disease, and clearly that specialists can't stay in our ivory towers. And before I finish with the thank yous, that there are a couple of other people I do want to thank. One is CIHR for their continued support of the NCRTP program, and for Mark's fantastic leadership. He's really taken over this program that Jenny developed and really run with it. And kudos to Jason Grebley and to Nagla Shukri for starting this HCV symposium, because I think this is now a highlight really of the NCRTP meeting and of the Castle meeting in general. And I think this year's meeting was I think we followed in that tradition. And I would like to thank not only CIHR for supporting NCRTP, NCRTP, but they have supported this meeting with a dissemination grant all 3 years that we've done it. And so thank you again for that support. And of course, thank you to our industry sponsors, because we could not put on this meeting without their support. And then the last two people that I want to thank deserve all the thanks, really, for making today happen. So the first one, Mark already mentioned her this morning, but Norma Shusha, who really likes to stay in the background and is a bit shy about receiving the accolades. But I can tell you, I may have so-called chaired this meeting, but really Norma did absolutely everything. My involvement was to say yes when she asked me a question. So it was... she really organized everything from putting together inviting the speakers, arranging their travel, arranging the accommodations, the space, helping us put together the program along with the scientific committee. And so I really do want to thank her. And the other person that gets a huge thank you is Sonia McParlin, who has been a huge help in putting together the meeting. And meanwhile, she was delivering a baby and then is supposedly on maternity leave, but of course is here today and has been involved in, again, every aspect of putting together the meeting. And so I really want to thank Norma and Sonia for their help, because we certainly couldn't have done it without you. So a little round of applause for them. And I will finish my comments and let us get to the reception and the poster presentations, which are outside, with one final thing. Jason last year put together a publication summarizing the contents of the meeting. And so for those of you who didn't get it, there are probably still copies of that was published in the Canadian Journal of Gastroenterology. You can pick up a copy of the meeting summary from last year. And I think we'd like to do the same thing this year. So I will be calling on some of the speakers and presenters to help summarize some of the sessions, and so we can have a record of the meeting. And I'll just make a little plug that I hope that we will do this meeting again next year in coordination with the CDDW CASL meeting and NCRTP meeting, which will be in Banff, next year, hopefully in slightly more beautiful surroundings than downtown Toronto. And with that, I will thank you again for coming and invite you, please do not run away. We've got some fantastic posters outside. The trainees have really put together some great work. So enjoy a glass of wine and some snacks, and take a look at the posters. Thanks a lot.